for a time of fellowship and for a time of togetherness. So before we get on with the proceedings, in order to invoke the blessings of the Lord Almighty, may I request our beloved Chaplain Achin, Reverend Father Thomas Varghese Achin, to say a word of prayer.
നമുക്ക് പ്രാർത്ഥിക്കാം. പിതാവിനും പുത്രനും പരിശുദ്ധനും സ്തുതി ആദ്യം എന്നേക്കും തന്നെ. ആമേൻ. പരിശുദ്ധനായ ദൈവമേ, സ്വർഗ്ഗസ്ഥ പിതാവേ, ഈ വ്യാഴാഴ്ച ദിവസവും ഞങ്ങൾക്ക് ഈ തിയേറ്ററിലേക്ക് കടന്നു വരികയും എന്തെങ്കിലും പുതിയ കാര്യങ്ങൾ കേൾക്കുവാനും അത് മുൻപോട്ട് ഞങ്ങൾ കൊണ്ടുപോകാനും ഒക്കെ കിട്ടിയതായിട്ടുള്ള വലിയ അവസരത്തിനായി നന്ദി. ഡോക്ടർ ഫിന്നിയെ പ്രത്യേകമായി അവിടുത്തെ കരങ്ങളിലേക്ക് ഏൽപ്പിക്കുന്നു. അവിടുത്തെ സാന്നിധ്യം കൂടിയിരിക്കുകയും ഞങ്ങൾ കേൾക്കുന്നതെല്ലാം ഞങ്ങളുടെ ഹോസ്പിറ്റലിന് പ്രത്യേകിച്ച് വരുന്ന ജനറേഷന് ഒക്കെ അതൊരു അനുഗ്രഹമാക്കി തീർക്കുകയും ചെയ്യുന്നതിന് പ്രാർത്ഥിക്കുന്നു. വന്നിരിക്കുന്ന എല്ലാവരെയും ഒരുമിച്ച് അനുഗ്രഹിച്ചാട്ടെ. യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ. പ്ലീസ് ബി സീറ്റഡ്.
Today, we have our senior consultant and head of the Department of Endocrinology to talk to us about the practical approach to management of osteoporosis, a very important and pertinent topic. Without much ado, may I request Philip Finney, sir, to take over.
Good morning, friends and colleagues. Thank you for coming for this meeting. And I hope that the next 35 minutes, when I share with you about some of the newer management of osteoporosis as it is done currently, will help us to probably recognize this problem, which is a major issue today, and also to probably know the general principles of when to refer and how do you treat patients with osteoporosis. So I want to thank the management for giving me this opportunity to share a few words. At the end of it, I'll try, we should be finishing 45 minutes totally. So I know that many of us have rounds. So the last 10 minutes, we'll have time for question and answers. So I want to start off with a very practical approach, and I want to give acknowledgements to many of my colleagues in Velo who have generously shared their slides and given me some of the newer thoughts which they have been doing research in this field, and so that it will be helpful to maximum number of participants today. I also want to welcome all the participants online who are watching from Bangalore, Vellore and other places across the country, and I hope that you will also have a very productive time. So osteoporosis is one of the three big illnesses I treat as an endocrinologist. The number one is diabetes mellitus, which is such a pandemic almost today. Second is hypothyroidism and thyroid illnesses, and the third is osteoporosis. But all these three illnesses have something in common. 1 in 2 patients doesn't know they have this illness while they walk around in the community. It's nearly a 50%. 50% of diabetes still is under-recognized or unrecognized in the community. 50% of patients with hypothyroidism, unless you screen, you will not pick it up. More so for osteoporosis, it's like a tip of the iceberg is what we are right now treating. And unless we recognize it or we know which are the patients in whom we should screen and pick up osteoporosis, you're never going to be able to treat them appropriately. So when I was training way back in 2003 in Vellore, we did a study where we looked at the rural women in the region around the Vellore hospital, and we did door-to-door surveys where we assessed what number of them actually have osteoporosis. Are we overestimating this risk? Is it really a problem? And in the regions around the Vellore fort, there is a rural community which was surveyed by my colleague, Dr. Thomas Paul, and they found that nearly 50% of women above the age of 50 years, or at least 5 years after menopause, have either osteopenia or osteoporosis. Have things changed over the last 15 years? The population in Tamil Nadu may be very different from the population in Kerala, or let's say West Bengal, but these are all, we don't have the data really to say that what is the prevalence of osteoporosis in Kerala. It is to our surprise that even though we have very many academic centers, we still don't have good data to say what is the burden of the problem of osteoporosis in Kerala. And actually, Dr. Indra, who is an associate professor in physiology, has just begun her PhD on this very topic of assessing what is the prevalence of osteoporosis in the communities in here around Kallupara area, as well as among our patients who are admitted with hip fracture. And with the kind collaboration of our orthopedic team, this project is just begun, and we hope to look at this over the next 3 years. And that is part of a PhD proposal. So the 50%, this is a recent study published in the Indian Journal of Community Medicine, and it shows that there has been about 1,500 women who were studied. And when they looked at the study, the prevalence still remains about 50%, which is very scary. 1 in 2 women in the rural parts of Vellore district have got osteoporosis. A common tool, everybody will not have a DEXA machine, which is the gold standard tool to assess whether somebody has got osteoporosis or not. So the WHO and many of the international agencies, the International Osteoporosis Foundation, have developed a clinical tool by which you can assess if somebody has osteoporosis or not. And that is called the FRAX tool, the Fracture Risk Assessment Tool. And that tool doesn't need the presence of a bone mineral density to be measured to say if you have osteoporosis or whether you're high risk for fracture. And there is a new parameter which has come in, which not many clinicians are aware of. That is called the trabecular bone score, which tells you a little bit more information about the bone microarchitecture, how it is. For example, one of the problems I have is 1 in 3 or 1 in 4 patients who comes to my OPD has got diabetes. And when we actually did studies on the bone density of patients with diabetes, surprisingly, we find their bone density is higher than the common population. So there are a lot of advanced glycosylation end products due to diabetes, which are probably interfering with the bone density measurements. So we have to have better tools to know if they have osteoporosis. And one of them, which we are supposed to be using in diabetics, is the trabecular bone score. But at this point, we don't have that particular tool in our armamentarium. The other important thing is when they screen women in this age group of elderly women, nearly 30 to 35% of women have got asymptomatic vertebral fractures, which is something which is like a silent epidemic. People are not aware. And that leads to a lot of the back pains. Of course, many of the back pains are due to mechanical causes like lumbar spondylosis, disc problems. But there is a significant number of them who have got vertebral fractures. Unless you do an X-ray or screen with a bone density, you will not pick this up. What about males? We generally tend to think this is a big problem among the women, and that's true, because till the age of 50 years, women are protected with estrogens. But after the age of 50 years, of say 55, little variable, after menopause, there's a sharp decline in the estrogen levels in women, which leads to a rapid onset of reduced bone density. And that's why we said after 5 years after menopause, we have a very high prevalence of osteoporosis. But how about males? In elderly males, we looked at this problem. And this study, which studied about 133 people, showed that in a mean age of 75-year-old elderly males, majority of them who actually had a very low dietary calcium intake, 1/4 of them in the lumbar spine, when they did a bone density scan, had got osteoporosis. Another 1/4 had osteopenia. The same is true almost for osteoporosis in the femoral neck, but osteopenia was much more. And I will talk about these definitions as we go on. However, the presence of vertebral fractures was only about 15% in elderly males. Now, what is the importance of knowing it? Many people are silently suffering from back pains which are not adequately recognized or treated. This is the India's premier society for study of bone and mineral research, the Indian Society for the Bone and Mineral Research. This is a consensus guideline which has come from the All India Institute of Medical Sciences, and many of the authors from across the country, right from Chennai, Bombay, and other places. And they say that all women above the age of 60 years and men above 65 years should be having a bone density scan done. But somehow people are not adequately aware of this condition, so we are actually not doing so many scans. And in most parts of our country, we don't have a DEXA machine, so we will not check it. But the age limit is lowered in menopausal women, postmenopausal, if it's below 60 years, or 50 to 60 years, if you do have the risk factors for developing osteoporosis. Even those who have got very low body weight or prior low trauma fractures are those people who may be at higher risk of having osteoporosis. And those who have fragility fractures before the age of 50 years, for example, a hip fracture or a Colles fracture. Many people fall on the outstretched arm and have a Colles fracture. Not everybody fractures, but those who have low bone density are the ones who fracture. So the Indian Menopause Society, which the gynecologist will be familiar with, all women above who are finished 5 years after menopause must definitely have a DEXA scan. Women with fragility fractures, those who have radiological evidence of osteopenia or compression fractures must have a bone density done. And one of the concerns we have is many people are put on anti-osteoporosis drugs without a baseline bone density. So what do we have to compare when you treat it after a year or so? You need to have a baseline, right? So it's very important to have a baseline bone density before you initiate them on anti-resorptive agents or parathyroid hormone, which are the other drugs which are commonly used. So the principle is screen all postmenopausal women if there are no risk factors above the age of 60 years and above 65. But if they have risk factors, which I will talk about, you must screen them maybe even earlier. This is a publication in the Archives of Osteoporosis in 2018 by my colleagues, and they looked at, in the CMC hospital Velo, who refers patients for DEXA. So I was talking to Mr. Shijil in radiology here and Dr. Vinod in radiology and say, who refers here? It is only the Department of Rheumatology and Endocrinology which are topping the referrals. But relatively, from general medicine, obstetrics and gynecology, and orthopedics are the next three departments, but much fewer referrals, even though we know this problem is big. Maybe the issue is cost. Cost may be one of the issues. Bone density for 2 regions costs about 2,300 rupees. So cost may be a factor. Among the many things, priorities of a patient, this may be the lowest priority. I understand that. But are we not giving them the standard of care which they need, especially if they are at high risk for a fall? So how do you meaningfully screen them? And you can't do BMDs for everybody because there will be problems, because then patients may not be able to take treatment. There may be other issues. So this is the definition of osteoporosis. If the bone density is more than 1, you call it normal. -1 to less than -2.5 is osteopenia, and a T-score, that is means you're comparing the bone density of a patient with a young, healthy 45-year-old lady. A healthy young lady, if you measure the bone density, and if it's less than -2.5 standard deviations below that, that is when you call it a osteoporosis. And that's a definition. This is the bone density machine which we have in our department here as well, which is used to measure the bone density. The other big problem is these DEXA machines are quite expensive. They cost about 30 lakhs, 40 lakh rupees, and not every center can afford it, and many people are not even aware of the importance of checking the bone density. For example, in Australia and various countries, in the US and other places, they did how many DEXA machines is ideally recommended according to the International Osteoporosis Foundation for a million population. The minimum is about 10.6 DEXA machines you need to have. And in India, we only have about 0.26 DEXA machines for a million population, where it should be about 10. So about 50 times or so many times less. Cost is variable in different, depends on which center you do it in, 1,000 to 2,200. And there's no point in really doing only one region DEXA. You must at least do 2 regions DEXA if you have to draw meaningful interpretations, because there are a lot of false positives as well. If you have a lot of osteophytes on the X-ray, or if you have lumbar spondylosis, you can get falsely elevated BMDs. Elderly people is on whom we do the DEXA if you have aortic calcification, if you have disc calcification. These are all conditions which can falsely elevate BMD. So you need to look at least 2 regions, the lumbar spine and the hip, if you're doing a BMD. But if somebody's had a fracture in the hip, you could use the forearm as a 3rd region where you can measure the bone density. So the limited availability of DEXA is a concern, far below what is recommended by the International Osteoporosis Foundation. And the cost and affordability is a big thought, I think, which runs through all our minds as we consider ordering a DEXA machine. There are 140 million women who are above 50 years in India. So it's practically impossible to screen all women. So I think we must also think of smart strategies to be selective in whom we should do a DEXA machine. And that's where I think the community team members who are with us probably can help. And even we can use these tools to screen our patients coming to the OPD to see where is the high payoff value worth doing a DEXA machine. That's what I'll talk about next. So different screening tools have been devised for community use and for outpatient use in various peripheral clinics. Whom do you refer for a DEXA scan? Agreed, the guidelines say screen everybody, but it's not practical. So how can we screen out some so we get very high payoff? And the various tools have been studied, and so many of the tools are actually very simple. We just need the age, we need the gender, and we need the weight. And we're using these 3. There is a formula which has been calculated. So This is as one of the tools which is used to screen for osteoporosis called a score, the simple calculated osteoporosis risk assessment. And if they score more than 6 points, you can say that they are high risk for osteoporosis. We can document osteoporosis and probably start treatment. You don't have to do for everybody. OSTA is the most validated screening tool which is used in the community, in peripheral clinics, primary health centers across the globe to screen for osteoporosis. Then there is another 2 scores also which are available. For example, I will talk a little bit about one of these 4 scores. The OSTA score, which is osteoporosis self-assessment tool for Asians. You just need the age and the weight as a simple tool. This, all of us can do that in our OPDs. Maybe even our nurses can help us to quickly calculate and tell us a score for elderly people. I'm sure the geriatric team can probably are using it. It's a readily available, rapid, easy to perform, inexpensive, outpatient-based tool for physicians to refer. So if you look at this, we look at the weight in age minus age into 0.2. So let's take an example. We have a 67-year-old lady who weighs 52 kilos. So what is the weight in kg? 52 minus 67 will come to minus 15 into 0.2. So you get the score as minus 3. And so you know that it's less than minus 1. So this is a person who's at high risk. So this doesn't need much parameters to make a diagnosis. But this is a fairly good screening tool, and they found that very high correlation using this simple tool to say if they have osteoporosis or not. And maybe you can even think of starting. But you can never start osteoporosis treatment without having a baseline DEXA in the ideal setting. So the WHO and the International Osteoporosis Foundation said, but still it is not good enough to start treatment. Everywhere we don't have a DEXA machine. What should we do? So Jack Canis is a gentleman who's a scientist in Sheffield University in the UK. He brought out this tool which has really helped clinicians across the globe to be able to diagnose osteoporosis without having a DEXA machine. So many of us can use this also as an option if the patient cannot afford it. This is a fracture risk assessment tool which any of you can Google on your smartphones now. You will get this. Just put in FRAX and you will get this tool. And in it, you have to enter a few data into it. The age of the patient, the gender, the height, weight. The fact that your parents have had a hip fracture makes you at a higher risk for hip fractures. That also tells you a little bit of the genetic susceptibility, I suppose. And the previous fractures make you much more at higher risk for developing a fracture. Use of steroid use, which is very rampant in the community. At this point, I have only 3 admissions under me in endocrinology, of which 2 of them have abused steroids, and they have landed up in osteoporotic fractures and problems. Smoking is a high risk factor for osteoporosis, as well as alcohol, which is often not adequately mentioned by patients to us, but alcohol use commonly is a very important cause for osteoporosis. In fact, if a male patient comes to me with osteoporosis, there are only one important question I ask them. Do you consume alcohol? How much? And if you don't take the proactive effort, you will not. And alcohol is a strong toxin to the bone health. So just one more point is that the 10-year risk, basically if you fill up this questionnaire and you click a button, submit, you will get the 10-year risk of having a hip fracture. If it's more than 3% risk, and if multi-site osteoporotic fractures risk is more than 20%, which is what the calculator will tell you, they say that you can even treat, even if the patient cannot do a bone density. That is what the recommendation is. So this is something which all of us can consider as an option to treat osteoporosis if they cannot afford doing a DEXA. But if it's you and me, if we can afford 2,300 rupees, I think it's something which will be worth considering. So in any patient who comes to us with suspected osteoporosis, the history and the clinical examination is extremely important to try to find out. I was telling you about my 3 inpatients I have. One of them is a teacher in one of the well-reputed schools nearby, here in this Tiruvalla, Changanasheri region. She came to me with low cortisol values. But Dr. Appuni, who is a former physician, he had referred her from Pudupalli to us. And his concern was, she's putting on weight, but her cortisols are 0.4. So we asked her, are you taking any, because the most common cause of somebody putting on weight is Cushing's syndrome. But if you expect the cortisols will be elevated. But this lady, the cortisol is rock bottom. So I said, she must be taking some steroid from outside. And I asked her, are you taking any steroid? She said, nothing. She has only antihypertensive, sugar medicines, the glargine, insulin, and other things. And I was puzzled. So for 2 days, we have been cross-examining her like lawyers, finding out, are you taking something? No. Dr. Elsa, my colleague, quizzed her. My team members have quizzed her. We still can't find out. So yesterday, So on the rounds, I remember a dictum which was told to me by my physician, Dr. Alka in Vellore. She told me, assume all people with rheumatological illnesses, asthmatic problems, and skin diseases will have steroid abuse till otherwise proven. That's a dictum. So I went through the dictum again. I asked her, do you have any joint pains? No. Do you have any asthma, respiratory problems? No. Any skin problems? No. I said, nothing at all. Then she said, well, actually, privately she told me there is a private part of her body. She is taking a cream called Cosweight cream for the last 1 year for some itching in the groins. I said, can you bring it out? Fortunately, she had it in her bag. So after 3 days of admission, she brought out this Cosweight. It was nothing but clobetasol propionate. And that has been used for 1 year. And that whole region is looking very, very, skin has become thin because steroid use. But even topical steroids, if you use it for long enough, can lead to suppressed cortisols. That is a lesson. But it is very satisfying for us. We find a cause and then immediately I referred to Dr. Lissy for sorting it out because we wanted to know, can we give an alternative agent, for example, to try and bring down. Now, steroid abuse can come in silent ways. It's much less in India, much less in Kerala, but even we completed a study in Koni area recently where we found that there is a prevalence of oral steroid misuse even in educated parts of our state. So I just want to just mention that steroid abuse may be surreptitious, may be quite subtle. We may not pick up the question. So history and clinical exam is important. We must do the bone biochemistry, especially a calcium, phosphorus, vitamin D is a simple blood test we do along with an alkaline phosphatase. And the DEXA machine is something which we can do a DEXA scan if they can afford it. Treatment, general measures are equally important, that is ensuring adequate calcium and vitamin D. We did a survey when we were in CMC, and we looked at what is the average calcium intake of Indians in Tamil Nadu, West Bengal, Kerala, patients who came. And we found actually many of us take very poor calcium in our diet. The calcium intake, if you actually measure it, if you go to Jyoti, our dietitian, I'm sure we all don't take enough calcium in our diet. And that is one of the risk factors. And women accrue maximum bone mass in the age group of 15 to 25 to 30 years. In that period, if you have not taken enough dairy products and calcium-containing foods, you are at higher risk for developing osteoporosis in the later years. The window of opportunity is in the young age, from 15 to 30 years. So anyway, this is the risk factors. Dr. Sam Chitranjan was discussing with us when we were doing this PhD project discussions with Dr. Charles and Dr. Indra. We were wondering, who are the ones who are at risk of osteoporosis? There is a substrate and there is also these environmental factors. It's not only the individual factors which are risk factors for osteoporosis. For example, if you are advancing age, as you grow older, you will develop osteoporosis. That's true, but not everybody develops osteoporosis. If you are consuming alcohol or smoking, if you take steroids or thiazolidinediones, which we use in diabetes infrequently nowadays, if you have many years postmenopausal, a lady who's 20 years postmenopausal as compared to a lady who's just 5 years postmenopausal, obviously more osteoporosis in the older age group. And those who have low BMI, thin body build, have got higher risk of osteoporosis as well as low physical activity. And many of us are culprits. We don't take enough calcium and vitamin D in our diet. But then I think the other big group which we should be concerned about is those who have neurological illnesses, proneness to falls. These people also fracture. Because even if you have a low bone density, if you don't fall, you will not really have an osteoporotic fracture, right? Drugs which will take, many of our patients are on too much antihypertensives and they get severe postural drop in BP in the elderly group in particular, which is making them a risk factor for a fall. People with rheumatoid arthritis and unstable joints, many people have osteoarthritis of the knees and they're a bit wobbly, they may fall and they'll fracture, as well as those with peripheral neuropathy in our diabetic population, more so in the other groups as well. Sarcopenia is a big problem in the geriatric group, muscle strength is less, so you're likely to strip and fall even with a small stimulus. And those who have cataracts and poor vision. So this is, if any of our elderly people, many of them have one or two of these factors, that is a risk factor for a fall. So these are people who are at high risk and you must probably consider doing a DEXA scan along with a basic blood biochemistry in this group of patients. And right now, I get complaints from the radiology team that we are not utilizing our DEXA machine well. We only do 1 or 2 in this hospital of 1,800 patients, sometimes on a busy OP day. We only use 1 or 2 DEXA scans the whole day. So that's really an underutilization of a precious resource. Actually, we want to upgrade this DEXA machine to a better machine where we can even measure the vertebral fracture assessment as well as the trabecular bone score. But right now, the economics are such that I'm not even able to justify to the clinical management team that we really need another DEXA machine or a better DEXA machine. So kindly, I hope the clinicians today will be sensitized to think of doing this if required. So interestingly, the dental health and osteoporosis, we don't think of it very often. Many of us, we are focused on our own areas like the lungs or the heart and things like that. It's an interesting study done in CMC where Nitin, my colleague, had looked at the tooth loss, and they found that mean tooth loss was different between subjects who had osteoporosis and those who didn't have osteoporosis. The odds of having osteoporosis in subjects who have more than 3 teeth gone is nearly 4.2 times as compared to those who don't have tooth loss. Just a connection that teeth loss may be connected to osteoporosis, at least an association. I'm not saying it's in any way causative, but it's important to remember to assess the dental health before you start on anti-osteoporosis treatment anyway, because bisphosphonates, the alendronate and drugs like this, can cause sometimes rarely complications like osteonecrosis of the jaw, which is a very rare side effect, but you must assess the dental health before you put them on anti-osteoporosis treatment. I know that you have been listening continuously to my talk, so I want to give you a clinical case. This is a 55-year-old lady who was postmenopausal about 5 years. She came with low back pain, very common problem. I'm sure most of these 54-year-old, 60-year-old women with low back pain will go to orthopedics to Charles and the entire team there. They don't often do much biochemistry. Orthopedics is very frugal in doing test investigations, I'm aware. But this particular patient had a bone biochemistry. X-ray surprisingly showed multiple wedge compression fractures. So what will you do? Can I just ask any one of you to ask, what will you do if you see multiple wedge compression fractures in the spine? Bone density was done, it was minus 4.2 in the neck, femoral neck, and minus 6 in the lumbar spine. Shall I put the patient on alendronate? Should I put on teriparatide, that is parathyroid hormone? What would you like to do? You can just shout out, no harm. Anybody? Maybe you're feeling shy. That's okay. So this patient, interestingly, was very short. And the clinician who saw this patient noticed that she had actually a slight bluish sclera. And there was osteogenesis imperfecta was the clinical diagnosis. And osteogenesis imperfecta is the severe variants will present in childhood with recurrent fractures. But the milder variants may come much later. And so this patient was later on proven to have a genetic variant of OI, which is something which was causing her, because the basic bone biochemistry didn't show any evidence of osteomalacia or any other metabolic bone disease. So physical stigmata of congenital bone fragility includes bone sclera, poor dentition. Ehlers-Danlos syndrome, we have all heard in the textbooks. It's a rare disease which can be coming with easy bruising, skin laxity, and joint hypermobility, as well as short stature kyphoscoliosis. But anthropometric measures can be used, and this is published in the British Royal Society of Medicine's their Tropical Doctor Journal. It's a very well-read journal across many parts of the world, in Africa in particular. The utility of anthropometric predictors in predicting osteoporosis in ambulant community-dwelling women in southern India. And this study showed that weight has got the best correlation for neck, femur fractures, and lumbar spine. And when they did multivariate analysis, weight and age are significant predictors for predicting femoral neck osteoporosis. So if you have a very thinly built lady, underweight, you can be fairly sure she will have osteoporosis if she's a postmenopausal woman, for example. It's a very sad, one of my anesthetist colleagues in CMC is my good friend. He was only 45 years. One day he went with a little bit of vague low back pain, and the sodium was checked for him as part of the panel. You know, sometimes we do this panel of tests, which is dangerous. No? The panel showed he had hyponatremia of 130. So he went to my colleague Thomas and he said, why am I having a low sodium? Now hyponatremia, I'm sure our physician colleagues see a lot of hyponatremia. So sometimes we try to work it up. But hyponatremia is not a diagnosis. I want to tell our young doctors, hyponatremia is only a symptom of a greater malady. Hyponatremia is like fever. You cannot treat fever. You can treat malaria, typhoid. You must be more specific. What is the cause of fever? So this young anesthetist, 45 years old, found hyponatremia. And because he had a low back pain, my colleague ordered a test. And it turned out to be serum. He found that the LFT had been overlooked by many clinicians at CMC. It was found that there was a subtle AG reversal, and the ESR was mildly high. Made him suspect myeloma. At the age of 45, he was diagnosed with multiple myeloma. Today, my colleague has already had the bone marrow transplant, and he's treated. So this is picked up early from a subtle clue of hyponatremia. Why am I saying that is, multiple myeloma, you don't have to wait till they are very florid and very sick. It's an indolent, slow-growing malignancy, as many of you know. They can sometimes come with not only typical lytic lesions in the skull and pelvis, which is the classical presentation, but some of them may come with a diffuse osteoporosis. So my dictum is, in above 50, 60 years, if anybody comes with a diffuse osteoporosis, don't forget about myeloma. That's a condition which can sometimes present as a diffuse osteoporosis. And you must look carefully at the AG reversal, the ESR, some of these. They may give clues. Maybe you order a serum protein electrophoresis if it's appropriate. Endocrine conditions, hyperthyroidism, we treat a lot of patients. They have a low bone mass. Hyperparathyroidism can lead to osteoporosis, steroid excess, and hypogonadism, both postmenopausal, when they have a hypogonadism because of ovarian failure, or even younger Klinefelter's patients who come with hypogonadism. Rheumatology clinics have people with active inflammatory rheumatological illnesses. Many of them have got low bone mass. Chronic kidney disease, chronic liver disease, and COPD. And many of our COPD patients are on steroids for pulses, or some of them have to take a low-dose steroid to prevent recurrent exacerbations. These are patients in whom you must recognize osteoporosis much earlier. Many of the drugs also can be culprits causing osteoporosis. Many of our neurology patients are on anticonvulsants, phenytoin, carbamazepine. These drugs can also be hepatic enzyme inducers and cause lower vitamin D levels with osteomalacia and or osteoporosis. A thorough medical history is important. Rohit is one of my juniors who studied in Velo. He published an interesting paper as an uncommon cause of osteoporosis. Let me see if any of you want to venture a guess. This patient came with back pain to the orthopedic OPD. And if you look carefully, can you see that at the back? Can the students see it at the back? One of you is sleeping. Hello? Yeah. So the height of the bone, the vertebra is little bit less. If you look carefully, you can see the height of the vertebra is reduced. Right? And if you see that, that is a clue towards osteoporosis. So this patient came, she is about 45-year-old gentleman who came with osteoporosis. Remember, a male osteoporosis, you look at it more carefully, because you may find an easy treatable cause. I told you alcohol is number one. Second is steroids. Is there any endocrine cause which causes osteoporosis apart from what I put on that list? Hyperthyroidism, steroid excess, hyperpara. Anybody? Is there any pituitary cause of osteoporosis? Anybody? Any hormone in the pituitary which goes up and suppresses your estrogen level? Prolactin. Now that's a hormone. Now, in a woman, she would have probably come with amenorrhea and galactorrhea. But this gentleman had actually erectile dysfunction, but he didn't talk about it. He's shy, and most of the men will not volunteer their information. So this patient actually had osteoporosis, which was documented on the T-scores being minus 3.5, minus 5. And then when we look carefully, this is the picture. Can you see that? Minus 3.3, minus 2.9. Severe osteoporosis in the spine in a young male. That made us screen for secondary causes of osteoporosis. And what we found is his prolactin was 2,692. Isn't that very satisfying? Whenever I see a high prolactin, that's one of those few conditions I enjoy treating. Because that's something when you can easily bring down with cabergoline, and many patients come with this fear. The other day I had a lady who came to me. Prolactin was about 2,000. The gynecology colleagues had done the MRI already, and there was a small, subtle microadenoma. She couldn't sleep for 10 nights because she was so worried she'll need a brain surgery. But I told her, you don't need surgery. We have cabergoline, a wonderful medicine which will get you almost 50% chance of remission in 3 years. So we put her on cabergoline, her prolactin normalized, and she's doing well. But this patient, if you look at the pituitary MRI, there's a large pituitary macroadenoma, which is causing the hyperprolactinemia, which has in turn led to osteoporosis. So patients may come to different specialists at the first presentation. Unless we have a broad understanding, we could miss the diagnosis. So it is very satisfying. So this is written up in the Indian, Family Medicine Journal, mainly for family physicians to realize you can keep the possibilities in your mind. This is a very interesting patient. This is a little bit of a catch in this heading. It says a rare cause of exogenous familial Cushing's. When you say familial Cushing's, you're thinking of some rare endocrine mutation or some receptor problem, right? But the clue is exogenous. So this is actually a patient, 2 children. Can you see them? They are about 18 and 15 years old, who came with typical Cushingoid appearance. Is it visible to you all? They look quite chubby, Cushingoid. And these people were given health drinks by their parents. They can become nice and chubby. And there's an obsession with parents that we want our children to look nice and fine and little bit healthy. In the orange juice, they were being given every day some drops, which was given by one of the alternative systems of medicine to make them chubby. And this was actually nothing but steroids. We have seen many chubby kids in Roxol and Bihar who come to us, 8-month-old babies who look really round and cute. but they have exogenous Cushing's. You check their cortisol is not detectable. They're given steroid drops for health purposes. So this is a family who had osteoporosis, these two boys, and they were being in steroids in their health drinks. Anyway, sometimes entire families will have it because of osteogenesis imperfecta genetic variations also leading to osteoporosis. So all patients where you suspect osteoporosis, I would say the simple investigations which anybody can order in this particular room who are working on the clinical side would be to ask for a calcium. Phosphorus is affected by food. It can go up and down, so it will be good to do a phosphorus in the fasting state. Calcium is not affected by food. Creatinine and an alkaline phosphatase. I think these are the only 4 investigations I ask for in most of my patients. Even vitamin D is not mandatory to order. Ordering a vitamin D costs 950 rupees in my hospital here, right? So sometimes the treatment is cheaper, giving 30 rupees per sachet of vitamin D. Sometimes easier to treat, but for academic purpose, it will be good to document the vitamin D, but not insisting on it. Bone turnover markers, I noticed that in this hospital, many of us don't order bone turnover markers when you treat patients with osteoporosis, but this is a useful tool which I will talk about a little bit later. And parathyroid level PTH also can be measured, especially if you're going to put them on PTH therapy, you may want to measure the serum PTH. If the PTH is already high, they have secondary hyperparathyroidism due to vitamin D deficiency, you may not want to give them teriparatide because you already have endogenous PTH being high. There you may want to give an anti-resorptive agent. So radiology, a simple X-ray of the lumbar spine and thoracic spine is useful to detect fractures, but X-rays don't pick up many of the vertebral fractures. You need a DEXA scan to be more sure that you're not missing any vertebral fractures. DEXA scan is useful for diagnosis of osteoporosis. And the newer tools, actually these are only software modifications on the existing DEXA machine, which we can buy the software for a few extra lakh rupees if we spend. It can be upgrades on our DEXA machine, the vertebral fracture assessment and the trabecular bone score. When relevant, screen for osteoporosis. Now, just one word about bone turnover markers. I know that many of you are not adequately informed about this new development. In the last 5 to 10 years, when you put a patient on alendronate or anti-osteoporotic therapy, you must monitor, are they responding to it? Remember, any patient on chronic medications, whether it's diabetic medicines or thyroid medicines, only 30% to 40% of patients comply. They take their medicines regularly. Many of them discontinue. So you'll give them alendronate for 1 year, you check the bone density after a year or two, you find there's no improvement and you wonder why. Very often it's because patient has not taken the tablet. That's what we find in most of our interviews. But some of them, it may be that it's not working or the drug is not working very well. You may have to switch to another agent. So bone resorption and bone formation are occurring in a dynamic equilibrium in the bone. And there's a balance. But if the bone resorption after menopause in women is higher than the bone formation, that is why women are much more prone for developing osteoporosis. So one of the bone resorption markers we check is the C-telopeptide of type 1 collagen. And the bone formation marker, alkaline phosphatase and osteocalcin was what was used before. Now we use P1NP as a marker of bone formation. It's not mandatory, but I think these are patients you could refer to endocrinology and we'll probably help you in monitoring their osteoporosis therapy. This is other densitometric adjuncts, which I hope that one day if all of you order DEXA machines a little bit more selectively and when it's essential, we will justify that we can buy a better DEXA machine, but preferably a hologic machine is what is on my dream. And we can probably also do a vertebral fracture assessment, which will pick up vertebral fractures earlier than it appears on a radiological X-ray. And also the trabecular bone score is also a software calculation where you can look at the bone microarchitecture and see whether they have osteoporosis. I told you diabetics are one cohort of patients which are very common. Diabetic patients have a higher BMD than their normal counterparts. That's the danger with type 2 diabetes. You may underestimate the prevalence of osteoporosis unless you do a trabecular bone score. So these are the non-BMD DEXA derivatives. Additional information you can get about bone strength. We also have something called the HSA, the hip structural analysis. Is a new development in the field of assessment of osteoporosis, which is done routinely in top centers in our country, in the All India Institute of Medical Science, Delhi, in Bombay, Vellore. But here we are not using HSA as a better tool to assess if they have poor bone strength. So we have something called a buckling ratio, how much the bones will buckle based on certain computer calculations of the bone density. So this is a study from CMC where they looked at proximal hip geometry trabecular microarchitecture and prevalent vertebral fractures. Are they different in postmenopausal women type 2 diabetes? This is insights from CMC, and they have said that they found that many of them have a low trabecular. Can you see the trabecular bone score? In cases is 1.1, it is and the controls is 1.25. So this is a significant drop in trabecular bone score in diabetic patients. Whereas if you look at their bone density, it was not. It was actually higher in the diabetic patients as compared to the controls. Can you see the difference? So you could be misled if you go by the traditional bone density measurements or the T-scores to see if your diabetic patient has got osteoporosis. So this particular information tells us it is ideally good to use a trabecular bone score, and I hope we will probably be able to upgrade our bone density machine soon. The paradox is, as I mentioned, the carry-home message is bone density can be deceptively high in type 2 diabetes. So how do you treat osteoporosis? The last 5 minutes, I will quickly conclude, is that you must ensure adequate dietary calcium, encourage physical activity, weight bearing in elderly people, building up muscle strength, prevention of falls are very good ways by which you can build up bone strength, muscle strength. Avoiding alcohol and smoking is a cornerstone in treating osteoporosis, and fall prevention measures. I remember in the UK, I'm very happy in all our staircases here we say it's watch your foot. In the UK and all, its falls prevention is given so much of emphasis because one hip fracture, the expense for the institutions are huge, especially in the National Health Service, and more so here, patients who have to pay out of pocket. It's a big burden, and after a hip fracture, many patients are dead within 1 or 2 years. So you want to prevent a hip fracture at any cost. So the women should ideally have a calcium intake of 600 mg per day. So we recommend 1 to 2 tablets of Shell-Cal or Abocal or one of these calcium supplements. 500 mg of elemental calcium is what is present in 1 tablet of calcium. So you must give 1 to 2 tablets. If they take good amount of dairy products, maybe 1 tablet is fine. So 500 to 1000 mg a day, and you need to give 1000 to 2000 units of cholecalciferol, that is native vitamin D3. But practically, to remember to take tablets, most of our patients are on 10 tablets. Right? Polypharmacy is common in our older population. They have heart disease, diabetes, BP, and all, so many things. So I recommend that take 60,000 units of cholecalciferol once a month. It's something easily done. It's available in sachet or tablets, whatever the patients want. So today I've tried to simplify. Pharmacotherapy is basically only 2 groups of drugs. You have the anti-resorptive agents, which will prevent the bone resorption. I told you there's a dynamic equilibrium between bone formation and bone resorption. You block the resorption, so you have a better bone density. And the commonest drugs we use are bisphosphonates, like alendronate or IV zoledronic acid once a year. Or denosumab, which some of our patients are able to afford. I have recently, yesterday, a patient came who has severe osteoporosis. She said she has got gastroesophageal reflux. She said, I can't take that. I asked her about zoledronic acid. She doesn't want to develop fever or flu-like symptom after her infusion. So I told her, there is an expensive option, denosumab. How much? 20,000? No problem. She as a bat of an eyelid, she said 20,000. So there are some patients who have no issues about cost, and she comfortably took her 20,000 injection and went. Every 6 months, she has to take denosumab for the next 5 to 6 years. So anyway, that's a different matter. But parathyroid hormone is actually another option we give, where we improve bone formation. PTH, teriparatide. And this is a patient who can be given teriparatide. We don't give PTH for everybody. It's like an insulin injection. Every day you have to give a subcute injection. But you can give it, but you must take it for a minimum of 2 years. There's no point starting. I see, sadly, many practitioners who start PTH for 1 month and they stop it. There's no point. You build up the bone, you must give it at least for 1 to 2 years, and then you must follow it up with bone anti-resorptive agents. Only then you sustain the gains made in improving the bone density. So then there are also some newer drugs which have come. So this is a whole armamentarium for just for your knowledge. You can just look at it. Bisphosphonates are alendronate, zoledronic acid. Ibandronate is used once a month. Zoledronic acid is used once a year. Risidronate for people with bad gastritis. Denosumab is a new kid on the block for the last 5 to 10 years. In the UK, for example, nurses give it. Doctors are not even involved in the care for preventing osteoporotic fracture. Parathyroid also TH. So if they have vertebral fractures, the best drug of choice is actually PTH, 20 for 24 months, zoledronic acid for at least 3 to 5 years, and denosumab. Teriparatide is not the and I'm not going to go through the entire thing and bore you, but I'll just say that in women who have got hypogonadism, and this is something you must ask them for erectile dysfunction and symptoms like that, If they have that, giving testosterone is probably the very good way to build up the bone density. So you must screen in men who come with osteoporosis. Apart from alcohol, the second most important cause is silent hypogonadism, which is not really overt and visible to us. Unless you check the testosterone levels, the prolactin levels, you can miss it completely. Giving them alendronate is short deficiency in care, what we offer. And this is low bone mass and Klinefelter syndrome, a publication from my colleagues. And I won't bore you with the details, but hormone replacement therapy, we use it very sparingly in women. Only when they have severe menopausal symptoms, where hot flushes, we use it. And teriparatide, only one thing you must remember about teriparatide, or PTH hormone. It's a daily subcute injection for 2 years. After 1 month, you must check the calcium. Some people develop a mild hypercalcemia. Every 3 to 6 months, you'd like to monitor their calcium. And I think with specialist care, we can also monitor their bone turnover. We expect that the bone resorption markers will come down when you give them anti-resorptive agents. And this is what we monitor, but today is not the time to discuss this in great detail, considering we have a heterogeneous audience here today. DEXA scan, don't need to repeat immediately after 6 months. You can check it after 1 to 2 years. So this is the bone markers. How do you guide anti-osteoporotic therapy? You look at the P1NP. It's similar to alkaline phosphatase and osteocalcin. It's the most reliable follow-up parameter for osteoporosis treatment. CTX, C-telopeptide, is an anti-resorptive marker. If both are elevated, your drug of choice is actually anti-resorptives. Now, we don't use our routine therapy is not guided by bone turnover markers because the cost of each of this is 1,800 rupees per marker. So a patient has to spend 3,600. But we do have a cohort of patients who come to us here, believers, who are well-read, well-educated. And for them, I do follow them up using bone resorption markers to treat their osteoporosis. This is the most scientific way of managing osteoporosis. But this is something which I will leave it. If any of you want to discuss after the session, we can talk about it. If their bone turnover markers are low bone formation and low bone resorptive markers, you can give anabolic therapy. So I'm not going to go to that. But basically, just want to show you that people who are given zoledronic acid, you find their bone density increasing nicely. Marked improvement in the lumbar spine, BMD, and femoral neck. So I've come to my last slide. So are we screening all our postmenopausal women for bone osteopenia, osteoporosis? This is something I want to just throw in front of you. I think we are not doing it adequately. And my plea to the physicians, particularly here, my orthopedic colleagues and my colleagues across specialties, is maybe look a little bit more deeper. There are patients who are not being given that therapy. I know there are a lot of other priorities for COPD, for example. You may have to treat the lung condition as a higher priority. But if they're on steroids, for example, you may want to screen them because the prevalence is so high. We need to rule out secondary causes. It's such a satisfying thing to pick up prolactinemia, hyperprolactinemia among people who have osteoporosis, and treating that will improve their bone density. Ensure good calcium and physical activity, treatment with calcium, vitamin D, all these things can be done. Just wanted to make you sensitize you that there is a new group of medications, tests called the bone turnover markers, which are used in following up people with osteoporosis therapy, and also to talk about hip geometry and trabecular bone scores are additional newer novel developments in the field of assessment of osteoporosis. So I hope I have sort of just given you a bird's eye view of the newer things developing in the field of osteoporosis, and I'm happy to take any questions. I'll hand over back to Jacob if you would like to moderate the discussions, or anybody can ask questions. So this is all, the last picture, a cute picture, which many nice ammachis sitting there. Many of them, I wonder how many of them have got osteoporosis. And this ammachi, many of these ammachis walk with a coon, like a little bit of that's called the Dowager's hump. Dr. Luke taught me that first when I was in Odanchatram with Sir many years ago, the Dowager's hump due to a osteoporotic fracture in the spine. So this is an ammachi who's got the Dowager's hump. And if you can catch them early, bones are fragile, bones are brittle, bones may break. Early screening, correct diagnosis, and correct treatment is very important. And I want to thank you all for your patient listening.
Thank you, dear sir, for that amazing talk. Questions? I'd like to hand over the mic.
Thank you, Renee, for the wonderful presentation. Apart from the steroids, one of the commonly prescribed misused drug is proton pump inhibitor. So once you search the prescription of every patient, you can see the PPA, one of the important drugs.
Yes, sir.
That can also lead to this osteoporosis. One question is regarding the osteonecrosis. I think this teriparatide also can produce this joint necrosis. And whether it occurs spontaneously or it occurs following a tooth extraction. and what's the mechanism of a osteonecrosis of jaw?
Yeah. In my understanding, sir, I have seen ONJ being described mainly with denosumab and with bisphosphonates. But I have not read the case reports yet with parathyroid hormone getting osteonecrosis of the jaw. It occurs usually after a tooth extraction, for example, they develop it. So that's why it's important to do a good dental assessment before you send them for a dental extraction. So a dental health assessment is crucial before doing it. The exact mechanism of it, there are a lot of postulates, but it's not really, we have not had a consensus exactly why it occurs in some people. Yes, madam.
Shahil sir said about parathyroid hormone you are not measuring earlier. Even if it is normal, you are giving this drug.
Yeah. So parathyroid hormone, if it is markedly elevated, ma'am, then giving extra parathyroid. Suppose the patient, we know vitamin D deficiency is rampant, right? Many people have vitamin D deficiency, but they can also have secondary hyperparathyroidism. If they have secondary hyperparathyroidism, then giving them extra therapeutic PTH may not be very wise. So we don't give it.
So you have to be careful. I thought
yes.
that hyperparathyroidism, so many complications.
Yes.
That's what he also said. Another, for me, Shelcal and for a life, is it wise we should stop it, Shelcal calcerol?
Yeah, there is a lot of fear about calcium. There's a lot of fear that calcium will cause kidney stones. I think that's unfounded. There is not really a risk. In people who have kidney stones, if the cause is hypercalcemia, as an underlying cause, only then we should avoid calcium.
Should we stop in between? I am taking
no, there's no
years.
concern about stopping it. And the calcium, there were some reports which had come of increased risk of atherosclerotic cardiovascular disease, but that study has not been substantiated. So we recommend for all postmenopausal women 1 to 2 tablets of calcium tablets, which have got calcium carbonate for at least long term. That's what we give.
Before we go on to the next question, next week at 8 a.m., Thursday at 8 a.m., we will have the talk on good practices in antimicrobial stewardship by Dr. Neto George from Department of ID, GMC Kottayam. So looking forward to all of you to participate in that program as well. And this program is being conducted to commemorate the World Antimicrobial Awareness Week by the Department of Microbiology. So any more questions?
Okay. Thank you very much for your patient listening. Thank you.
Thank you, sir, for that wonderful talk on osteoporosis and dissecting us the various nitty-gritties of it, and we are really grateful for that. And thank you to all those who have come today, and looking forward to more such amazing sessions. Thank you so much.
Thank you.